We have Dr. Tiliakos with us, who is the program director for the fellowship program in rheumatology, internal medicine training at Drexel, and did fellowship at a fine institution here, and stayed on as faculty and is well known as a great teacher, and so he's going to tell us everything about vasculitic, right? Everything we need to know in 50 minutes or less. All right.
Thank you so much. Can you hear me? Is that okay? All right. Thank you for the opportunity to talk to you today. Going to try to do a sort of an update on the ANCA-Associated Vasculitides. I have no disclosures. Let's start with a case presentation of a patient that we saw a few months ago. She's a 26-year-old graduate student at a local university. She had no significant past medical history. She presented here with a complex constellation of signs and symptoms. 4 months prior to her presentation here, she began to experience low-grade fevers, arthralgias, and weight loss. A month later, she began to develop nasal congestion as well as bloody nasal discharge, which was a new process for her. 2 months prior to presentation, she visited her local student health center. She was given a 5-day azithromycin dose pack with little to no symptomatic relief. 4 weeks later to that, she began to experience a persistent, progressively worsening, non-productive cough. She went back to the student health center. There, a diagnosis of a walking pneumonia was made, and she was treated with a 10-day course of levofloxacin. Again, little to no symptomatic relief. 2 weeks later, the cough became worse, and she began to experience lower extremity edema, which was, again, a new symptom for her. 2 days prior to presentation, she made her third visit to the student health center. This time, labs and a chest x-ray performed. She was called a few hours later and told to go to her local emergency room for further care. In the emergency room, she appeared ill. She was febrile. She had a normal white blood count. She was mildly anemic. She had normal platelets. Her creatinine was 3.8. Her urinalysis revealed a 3+ protein and greater than 100 RBCs per high-powered field. She had some type of left lower lobe consolidation on chest x-ray, and she was admitted for the concern of some type of pulmonary renal syndrome. Rheumatology, nephrology, and pulmonology were consulted. Our service was consulted, and as we're apt to do, we obtained a lot of labs. Our ANA was mildly positive of 1 to 80. Her ENA was negative. Complements were normal. Her C-ANCA was 1:320. Her PR3 was positive. Anti-MPO was negative. Viral Hep B and C serologies were normal. Her urine drug screen was normal. CT sinuses revealed a pacification of the ethmoid sinus cavities. Nephrology was able to spin her urine. There was evidence of an active sediment. Pulmonology also saw, we obtained CT scan of her chest. Again, these infiltrates persisted, and it was decided that the highest yield would be a renal biopsy, which revealed a post-immune crescentic glomerulonephritis. So the diagnosis of an ANCA-associated vasculitis manifesting as sinopulmonary disease, glomerulonephritis, in the setting of a C-ANCA pattern and anti-PR3 positivity. When you put all these factors together, the diagnosis of granulomatosis with polyangiitis was made. Here are the objectives for the remainder of the talk. I'd like us to understand the serologic testing in the ANCA-associated vasculitides, to understand the pathogenesis of the ANCA-associated vasculitides, and to understand induction maintenance therapies for the treatment of these conditions. Let's start first with classification criteria. So in 2012, a group gathered in Chapel Hill, North Carolina for a consensus conference. This was to improve the previous 1994 nomenclature. They changed names and definitions as appropriate, and they also added important categories of vasculitis. And it's important to note that this is a this is not really a classification system per se. It's not really meant to be a diagnostic system per se, but it's rather purely a nomenclature system. And there's always the danger when you come up with these classification criteria or nomenclature criteria that they get used as a diagnostic criteria, but that's not the case with this. So they came up with these groups of vasculitides. The large vessel vasculitides, which include Takayasu's and giant cell arteritis. Medium vessel vasculitides, which include polyarteritis nodosa and Kawasaki's. The variable vessel vasculitides, such as Behçet's and Kogan's syndrome. Single organ vasculitides, such as cutaneous vasculitis or primary angiitis of the CNS. Vasculitis associated with systemic disease such as rheumatoid vasculitis and lupus vasculitis, and then vasculitis associated with probable etiology. These include hepatitis B associated vasculitis, hepatitis C associated vasculitis as well. But we're going to concentrate on the small vessel vasculitides, which are vasculitides that predominantly affect the small vessels, the intraparenchymal arteries, arterioles, capillaries, and venules. We can divide these into two main groups, the ANCA-Associated Vasculitides and the immune complex vasculitides. Again, we'll concentrate on the ANCA-Associated Vasculitides today. Here's a cartoon just depicting the size of the vessels that we are describing today. And these are the ANCA-Associated Vasculitides can affect medium-sized vessels at times, but it's predominantly the small arteries, arterioles, capillaries, and venules that are affected. The ANCA-associated vasculitides include microscopic polyangiitis, granulomatosis with polyangiitis, which was formerly known as Wegener's, and eosinophilic granulomatosis with polyangiitis, again, formerly known as Scherg-Strauss syndrome. Microscopic polyangiitis and granulomatosis with polyangiitis can be distinguished usually between, besides the different ANCA antibodies, which we'll talk about soon, but granulomatosis with polyangiitis tends to affect upper respiratory tract as well as the lungs and kidneys in direct contrast to microscopic polyangiitis, which usually spares the upper airways. In addition, GPA also can cause granulomatous inflammation, which is usually absent in MPA. And then eosinophilic granulomatosis with polyangiitis is typically associated with hypereosinophilia as well as asthma. So for the next few slides, I'd like to get into these anti-neutrophil cytoplasmic antibodies themselves. And these are neutrophil-specific antibodies. And we're going to speak about proteinase 3 ANCA, myeloperoxidase ANCA, human leukocyte elastase ANCA, and human lysosomal protein 2. There are other antibodies that have also been shown to be present in the ANCA-associated vasculitides, such as anti-endothelial cell antibodies, anti-GBM, anti-phospholipids, but we'll concentrate on these 4 neutrophil-specific antibodies for the talk today. We'll start with PR3 ANCA. So in 1985, Vanderwood et al. Reported the presence of autoantibodies reacting with cytoplasmic components of neutrophils and monocytes in patients with formerly Wegener's. The antigen itself, PR3, is a serine protease that's present in both monocytes and granulocytes. It has proteolytic activity, and it's physiologically inhibited by alpha-1 antitrypsin. When you look at autoantibodies to PR3, they're usually detected by immunofluorescence on ethanol-fixed neutrophils where they produce a cytoplasmic pattern. It's been shown that patients with ANCA-associated vasculitis display significantly higher percentage of PR3 expressing neutrophils. It's also been shown that patients with higher membrane expression of PR3 tend to do worse clinically. The next antibody is myeloperoxidase. Falk and Jeanette, as well as Kallenberg et al., identified MPO as a major antigen for p-ANCA-positive sera in patients with crescentic GN and necrotizing vasculitis. It is present in the azurophilic or alpha granules of myeloid cells. They have critical roles in the generation of reactive oxygen species, and antibodies to MPR detected by immunofluorescence where they produce a perinuclear pattern. And I'll show you examples of the patterns a little bit later. Human leukocyte elastase ANCA is the next antibody we'll be discussing. It's the frequently targeted autoantigen in patients with drug-induced vasculitis or drug-induced lupus, and in those with cocaine-induced nasal destruction. It's rarely found alone. It's mostly accompanied by ANCAs toward other neutrophil antigens. It is exceedingly rare in idiopathic ANCA-associated vasculitis, but if it is the only ANCA contained in the serum, it usually produces a peripheral pattern. There's a lot of excitement as of late with human lysosomal membrane protein 2. It was first described in 78 of 84 patients with ANCA-associated focal necrotizing GN. This is controversial because some other groups have tried to replicate this and have been unable to. But HLM protein 2 has physiologic role in cell adhesion, autophagocytosis, and antigen presentation. It's integrated into the membranes of MPO and PR3 containing granules. It's also found on neutrophil and endothelial cell surfaces, especially glomerular endothelial cell surfaces. This is an interesting antibody here because it makes it directly, since it's on the endothelial cell surface, it's directly accessible to circulating antibodies. So here's a cartoon depicting the patterns that one gets when you order ANCA. So when you're ordering an ANCA, you're getting a pattern. You're ordering a pattern. So this is the C ANCA or the cytoplasmic and the P ANCA or the perinuclear. There's also an atypical pattern, which has both cytoplasmic and perinuclear patterns. And this is usually seen in drug-induced vasculitides, inflammatory bowel disease, and rheumatoid arthritis has actually been shown to give that atypical pattern. Here at Emory, when we obtain ANCA, it's done by immunofluorescence, and then the MPO and the PR3 are done via this multiplex bead assay, which is basically in a plate. You have microspheres that are conjugated with ANCA targets. They're incubated with the patient's serum, and then the immunofluorescence intensity is measured by flow cytometry. Here's another cartoon showing various antigens and the patterns of ANCA that they produce. So you can see here PR3 with the C ANCA pattern and MPO with the P ANCA pattern. But there's other antigens such as lysozyme, elastase, catalase, defensin, actin, which show their respective patterns as well. Here's a chart showing the frequencies of PR3 ANCA and MPO ANCA in various ANCA-associated vasculitides. You can see here that GPA has that PR3 ANCA is much more commonly seen in GPA, while MPO ANCA is much more commonly seen in MPA. You can see that the ANCAs are not always very helpful in the eosinophilic granulomatosis patients. And then you see MPO and more frequent MPO positivity in renal-limited vasculitis as well as the drug-induced vasculitides. So the question is really, that's great. We have these lab tests, but are they pathogenic? Do we know, are they intricately involved in the disease, or are they simply innocent bystanders to the disease process? So we have a couple of interesting cases. This first one by Schleibing et al. From the American Journal of Kidney Disease, which showed that an infant developing a pulmonary renal syndrome 48 hours after delivery was found to have serum MPO-ANCA titers similar to the mother. Another study by Silva et al. Showed that a newborn remained absolutely healthy despite persistence of MPO-ANCA in the mother. So two conflicting studies here. Shao et al. In the Journal of Clinical Investigation did a very nice, elegant study where they took anti-MPO immunoglobulin obtained from MPO knockout mice, and they placed it into these immune-deficient RAG2 knockout mice. And they were able to cause pauci-immune crescentic necrotizing GN in these immune-naive mice. So some evidence of pathogenesis. What about biomarkers? Are these tests good enough to be used as biomarkers? So the U.S. National Cancer Institute defines biomarkers as biological molecules found in blood, other body fluids, or tissues, which is a sign of normal or abnormal process or of a condition of disease. Burke et al. In the American Journal of Kidney Disease looked at 22 studies. There was wide variation, reported clinical utility of ANCA titers in these studies, and they found sensitivity of an increasing ANCA titer for diagnosis of relapse ranged from 24 to 100%. So not very helpful at all. What accounted for these discrepancies? First, variations in definition of remission and relapse. We still have arguments over what is considered to be relapse in these diseases. There's differences in follow-up time and between serial ANCA measurements, and also the techniques of the ANCA measurements are different in all of these studies as well, which probably contributed to some of the wide variation that you see. Can you use them to predict relapse? Well, Thomason et al. Did this large meta-analysis of 9 different patients, and they looked at the positive likelihood ratio and negative likelihood ratio for predicting the group under the A studies show a rise of ANCA titers, and then the B level show persistence of ANCA titers. And could they predict relapse by either a rise of the ANCA titers or persistence of the ANCA titers? So the authors did see that rising ANCA and persistently positive ANCA were associated with flare, but it is not enough to simply use these titers to guide treatment decisions. And it's a meta-analysis, so take it for what it's worth there. What about predicting relapse? Well, Boomsma et al. Looked at 100 patients with ANCA-associated vasculitis, and they followed them prospectively with serial ANCAs. 13 of the 37 patients who relapsed were ANCA negative at the time of relapse. So this study sort of showed that persistently negative ANCA did not guarantee disease quiescence. What about differences between PR3 ANCA and MPO in relapse? Well, Leonaki looked at this, and they looked at 500 patients with ANCA-associated vasculitis and biopsy-proven GN. PR3 specificity seemed to confer a twofold risk of relapse when compared to MPO. So what about biomarkers in ANCA-associated vasculitis? Monach and his group in Boston and one of the American vasculitis study groups looked at 28 serum proteins from the RAVE trial, and these proteins included SED rate and CRP. And the 3 that they found that found to be better at distinguishing active vasculitis and remission from others were these 3: CXCL13, which is critical protein in B cell homing, metalloproteinase 3, and then TIMP1, which is a metalloproteinase inhibitor. So these are not obviously clinically available. These are more done in a lab, but one can imagine in the near future some type of test where several factors are grouped together and some type of a composite lab or score would come out. So we'll shift gears a little bit and move away from the ANCAs and now towards the pathogenesis. And it's important to note that we still don't know, but these are hypotheses based off of the studies that we do have. So what's new in genetics? Lyons et al. Published this study in the New England Journal in 2012. They published this genome-wide association study, and they looked at over 10,000 patients. This included controls. And they looked at patients with PR3 ANCA-associated vasculitis had a strong association with HLA-DP, and then patients with MPO vasculitis had a strong association with HLA-DQ. What does this really mean? Why is this important? Well, it confirms that there is some type of genetic component. It also strengthens the argument that these may be 2 completely different distinct disease subsets. What about epigenetics? Well, levels of this protein complex called H3K27ME3 was found to be lower in ANCA-associated vasculitis patients And this protein complex is responsible for gene silencing, and this may have a role in aberrant expression of the MPO and PR3. Environmental factors. This is a very hot topic in the field of rheumatology, not just for the vasculitides, but many of our other diseases, rheumatoid arthritis, lupus, looking at various environmental factors. Silica has become popular at late. I know it's also implicated, sometimes implicated in lupus as well as other diseases such as sarcoidosis, propylthiouracil, penicillamine, hydralazine, and lifimazole have also been implicated. Hydralazine is interesting because it's shown to be a DNA methylation inhibitor, which might reverse epigenetic silencing of PR3 and MPO, which results in increased expression of both autoantigens in the neutrophils. Infections, again, have also become in vogue in our field. Bacteria such as staph, which I'd like to get a little bit more into. Typical viruses that are frequent culprits in our conditions, such as parvo B19, EBV, fungi such as aspergillus, protozoa, entamoeba, and strongyloides have also been implicated in the ANCA-Associated Vasculitides as well. So in the next few slides, I'd also like to sort of concentrate on the idea that infections may drive ANCA-associated vasculitides. And I like to bring up these four processes: autoantigen complementarity, molecular mimicry, toll-like receptors, and then the concept of netosis. So autoantigen complementary hypothesis asks the question, what if the initial response, what if the initial immune response is not directed towards the autoantigen, but rather a peptide that is complementary to the autoantigen epitope? So complementary peptides could arise from antisense transcription, shown here, of the autoantigen gene endogenously, or they can exist as microbial exogenous peptides, seen here, that mimic the complementary antisense peptides. So this is also a very attractive theory to those who favor an infectious etiology for the ANCA-associated vasculitides, because it also explains why patients are culture negative at the time of diagnosis as well. Pendergraft et al. Looked at this concept of complementary proteins. He immunized mice with complementary PR3, which led to the development of antibodies to both complementary PR3 and PR3 itself. Staph, entamoeba, and Ross River virus have all have peptides that are homologous to this complementary PR3, which may trigger the autoantibody response. The next sort of mechanism is this concept of molecular mimicry. So molecular mimicry refers to the development of antibodies to most proteins after exposure to foreign antigens. This occurs due to structural similarities between the host and the foreign proteins. And this has been postulated as a potential reason for the loss of tolerance to self and the development of autoimmunity. So remember LAMP2 that we discussed earlier, highly prevalent in ANCA-associated vasculitis patients, thought to be pathogenic, especially in the renal vasculitis patients. There is homology between LAMP2 and FIMH, which is a component of Fimbriae, on gram-negative bacteria. So this brings forth the theory that infection with gram-negative bacteria would generate antibodies to LAMP2, and eventually patients would develop vasculitis. What about toll-like receptors? So these are part of our innate immune system. They're expressed by monocytes, B lymphocytes, granulocytes, epithelial cells, and endothelial cells. They're able to recognize these structures called PAMPs, which stand for pathogen-associated molecular patterns. When toll-like receptors recognize these PAMPs, there's a release of pro-inflammatory cytokines, type 1 interferon, antimicrobial peptides, and effector cytokines. What about NETosis. So this is a relatively new concept in our field, and NETs stands for neutrophil extracellular traps. So this is, again, part of the innate immune system. So dying neutrophils extrude NETs to kill invading pathogens. And when they do this, they release antimicrobial peptides, they release the cytoplasmic MPO, PR3, elastin, cathepsin, and lactoferrin. I'll show you a diagram here. Here you see a regular unprimed, let's call it, neutrophil here that that is influenced by either infection, drugs, or various epigenetic effects. You have this neutrophil extravasation of their contents here, or NETosis. And when that occurs, you have this release of PR3, MPO, and various NET remnants. These remnants, these PR3 and these other NET remnants, are able to interact with myeloid dendritic cells here, which causes a transfer of MPO and PR3 to the dendritic cells, and this induces and promotes an adaptive immune response here. So unprimed neutrophils become primed by some type of infectious drug or epigenetic event, exudes these normally cytoplasmic proteins, which then releases them, and then our adaptive immune system then formulates a response. Here, I don't know how well you can see it here, but here's immunofluorescence that shows these NETosis. It's actually a beautiful, sort of elegant mechanism for that our innate immune system has. What about complement? So complement has always been initially thought to not be important in the ANCA-Associated Vasculitides, but it's been shown that serum and urine C5a levels are elevated in patients with active disease, and that priming neutrophils with C5a seems to enhance ANCA-neutrophil interaction. We'll talk a little bit about aberrant T and B cells. First, T cells, aberrant T cells. So autoreactive T cells from patients with ANCA-associated vasculitis have been shown to respond to MPO and PR3, while markers of T cell activity are increased in parallel with disease activity. Renal biopsy samples in patients with vasculitis show that the number of infiltrating T cells correlates with severity. Also, Schmidt et al. Were able to show the efficacy of anti-thymocyte globulin, which is anti-T cell therapy, in 15 patients with recalcitrant ANCA-associated vasculitis. So this further enhances the idea that T cells are heavily implicated in the disease. What about aberrant B cells? So there's been thought that B cells are not simply the antibody-producing cells, that they may have influence in other ways, such as influencing T cells through their antigen-presenting role. There's also been reports where B cell activating factor, BAFF, has been shown to be elevated, which we'll talk about later on when we discuss the therapies. Renal biopsies also reveal B cell infiltration in clusters in disease. And there's also a hypothesis that is it perhaps impaired B regulatory cells that are unable to suppress effector T cells that leads to disease. Here's a summation slide here of what we think causes the pathogenesis. So we have here circulating unprimed neutrophils are primed for activation by ANCA by inflammatory cytokines or C5a that's derived from complement activation. Primed neutrophils then release ANCA antigens, which are symbolized here by these little triangles, at the cell surface and into the microenvironment where they interact with ANCA, which is symbolized by these green antibody-appearing figures. The Fc receptor engagement by ANCA bound to ANCA antigen causes neutrophil activation. ANCA-activated neutrophils release factors that activate the alternative complement pathway, generating more C5a, which is shown here by these little blue circles. C5a and ANCA create this huge inflammatory amplification loop, with C5a attracting and priming more neutrophils for activation by ANCA. ANCA-activated neutrophils then marginate. They penetrate vessel walls. They undergo respiratory burst and degranulation, apoptosis, and necrosis. There's disruption of the endothelium, which allows plasma to spill into the vascular space, where activation of the coagulation cascade produces fibrin and fibrinoid necrosis. Then the innate immune system orchestrates conversion of initial activated neutrophil-rich inflammation into increased mononuclear leukocyte-rich inflammation and subsequent collagen deposition and fibrosis. And that's a hypothesis. That's what we think based off of the studies that have been done thus far. Let's go into a little bit about clinical features. This is for the residents in the room, but the diagnosis still remains largely unchanged. It's clinical features. Histological confirmation is, of course, the ideal goal. Sometimes it may not be warranted. ANCA serologies are very helpful. So positive immunofluorescence, so the pattern in and of itself is not enough. Should be followed by ELISA for ANCA specifically directed against the PR3 or MPO. Here's a table. The next couple of slides will show a table with various manifestations of the three ANCA-associated vasculitides. You can see here that GPA has the predominance of the upper ear, nose, and throat symptoms when compared to the others. They all can cause scleritis, episcleritis, and uveitis. GPA can also cause orbital pseudotumor, which is a potentially difficult and catastrophic manifestation. Segmental necrotizing GN has also been implicated in all three. Cardiovascular manifestations, there's occasional valvular lesions in GPA, usually absent in microscopic polyangiitis, and then eosinophilic granulomatosis has been shown to cause heart failure. GPA can cause cranial neuropathies, mass lesions, pachymeningitis, and vasculitic neuropathies. MPA can also cause vasculitic neuropathy, and vasculitic neuropathy is actually one of the prime features of eosinophilic granulomatosis. All of these can cause arthralgias and arthritis, usually arthralgias, but they can cause an inflammatory arthritis as well. And then our diseases can also cause palpable purpura, bullous lesions, papules, ulcers, infarcts, and splinter hemorrhages. Here's an example of a CAT scan with these cavitary lesions. Here's another view of these cavitary lesions. A section here that's showing alveolar hemorrhage into the right lung. Here's an example of lung biopsy. The blue arrows here are pointing at multinucleated giant cells. The red arrow here is depicting liquefactive necrosis, lymphocytes, plasma cells. And then the yellow arrow here is pointing at a small blood vessel, which shows destructive leukocytic angiitis. Here's an infrequent manifestation of GPA. You get this granulomatous inflammation of the gingiva here. Here is ulceration and destruction of the hard palate. You can also see that this patient here also has destruction of the nasal septum as well. Here's an example of the saddle nose deformity that is caused by inflammation and destruction of the nasal septum. An example of orbital pseudotumor with destruction of the orbit and surrounding tissues. Can be quite debilitating. It's a reminder of the upper airway manifestations of GPA, and what one can see is subglottic stenosis, which is, again, very difficult and can be catastrophic for the patient, frequently requiring tracheostomy. It's a renal biopsy for our nephrology colleagues here. The red arrow here points to destruction of the Bowman's capsule. The blue arrow here shows a cellular crescent. The green arrow here shows moderate infiltration of neutrophils and monocytes. And then the yellow arrow points to loss of many capillary loops and glomerular sclerosis. I'd like to start by, towards the end of the talk now, about treatment. And a little bit about treatment overview. We'll discuss the current paradigm that we follow and how we stratify disease activity. And then how we look at induction versus maintenance and how the role of B cells have really revolutionized the way we treat these diseases. And then we'll finish off by talking about some of the targeted therapies that are sort of in the pipeline now: T-cell targeted therapies, complement targeted therapies, anti-cytokine therapies, and then finally plasma exchange, which is a controversial topic. So we owe a great deal of debt to cyclophosphamide, which really was vital for the treatment of these diseases. It was near fatal, almost a fatal disease, nearly almost fatal disease until the advent of cyclophosphamide for use in these conditions. But we're always looking to do better for our patients and to do it with less toxicity and less side effects. So the start is this NORAM trial by de Groot et al., which looked at, first of all, this is for limited disease. And when we talk about limited disease, what we're usually speaking about is upper airway limited disease. And de Groot looked at methotrexate versus oral cyclophosphamide in patients with limited disease. Their primary endpoint was remission at 6 months, and they saw no difference in remission rates between the two groups, which was large. So this is the first time that we had something other than cyclophosphamide for limited disease. So what about severe disease, multi-organ system disease? So the Cyclops study, again by de Groot, looked at oral cyclophosphamide versus IV cyclophosphamide in new ANCA-associated vasculitis patients with renal involvement. The endpoint was time to remission. IV cytoxan was shown to be non-inferior to PO cyclophosphamide with lower cumulative dose and less leukopenia when compared to the IV. So we're starting to trend in the right direction here. We're trying to get away from some of the side effects of oral cyclophosphamide. And then the real sort of game changers, I guess we could say, were the two studies that were in one of the 2010 issues of the New England Journal article, which is the rituximab and the RAVE trials, where they looked at rituximab versus IV cyclophosphamide for induction therapy in the ANCA-associated vasculitides. So the rituximab trial looked at IV cytoxan plus rituximab versus IV cytoxan plus placebo in patients with renal involvement. Their primary endpoint was remission at 12 months, and they showed non-inferiority of rituximab to IV cytoxan alone. The RAVE trial done here in the United States looked at rituximab versus PO cyclophosphamide in new or relapsing ANCA-associated vasculitides. Their endpoint was a little bit different. It was steroid-free remission at 6 months, which is a little bit controversial as well. But they found that rituximab was non-inferior to cyclophosphamide for induction. Here's a diagram looking at the two studies head-to-head. Again, you can see the primary endpoints were different: sustained remission rates at 12 months for the rituximab, and then complete remission and successful prednisone taper by 6 months. The side effect profiles were relatively equal to the both. And the main difference between the two is because the RAVE trial also looked at relapsing disease, they showed that rituximab was superior to cyclophosphamide in patients who were already induced and are being re-induced for disease control. So what about maintenance therapy? So now our treatment paradigm, we've borrowed from our colleagues in hematology and oncology, where we try to grab hold of the disease via induction, and then we try to maintain the disease